in all of our lives there are some pivotal moments, both personally and in work. And one of the pivotal moments I've had was actually when I joined HealthPathways 3.5 years ago. It's very rare that you get the opportunity to make significant change, and this has allowed me to do that. I think in some ways you're a little bit further on than us in that some of the things, your starting structure has already been a little bit more developed than ours, and the passion that I've met today with the team that you have working for you is very, very good. So HealthPathways commenced in WA in 2013, and we actually started before WAFA. In 2015, WAFA came into existence and we became a statewide programme. Had its benefits, and obviously that had a few issues and difficulties that we had to deal with around that. In 2015, later that year, we actually developed a partnership agreement with WA Health. And it's really good to see that you actually have your South Australian Health Agreement set now, because I think that makes it probably much easier and a lot quicker for you to go forward, because we had a lot of work to be done in working with WA Health on how we were going to move things forward, how we were going to check pathways, how we were going to send them out to consultation so that everyone was happy with it. So you're already a little bit ahead of us, I think, in that aspect. So I was asked to talk about what our motivators, what was our motivation for doing this? And I suspect the same as most places. What I was going to say here is that even though our health system in WA was probably not broken, it was severely damaged. And then I found this slide. And there are broken systems, they're ineffective systems, and people who are trying to work with them because we refuse to change them. We have met in our journey in WA a lot of inspirational people. I know Graham's talked a lot about the hardships and the crocodiles. We found a few crocodiles, but not anywhere near as many hardships as he suggested. And I probably reflect on the matter that the climate has probably changed a little bit from when Graham and his team were starting to when we're starting ours, because there's a lot more buy-in and understanding that we actually need to make these changes than there probably was when Graham started. So what were our motivators? Like everyone else, long waiting lists, but particularly long waiting lists with a large number of people who probably shouldn't be on there anymore. Silos of care, spiralling costs, and obviously the realisation that with the spiralling costs we couldn't continue to provide an adequate medical service. What we had, particularly in our country areas, was competition for funding getting in the way of collaboration. We'd set up a system that made NGOs in country areas compete with each other for the same funding rather than work together. And that's something that we're actively working to change at the moment. Obviously, the lack of communication between primary and secondary care, which has been alluded to and has been there for a long time. I know, like some comments that have been made, you sometimes give up trying to refer patients because you continually got knocked back. And mental health was particularly an area of difficulty that, as a GP, I've often struggled in knowing where to refer and how to refer. Lack of services in country area. The beginning of last year, myself and some of the team went round all our 7 country areas to discuss with them issues. Now, yes, we found lack of services. We also found services that were overwhelmed. But occasionally we found services that had capacity, but no one knew about them. So this lack of knowledge of existing services was a big thing. In the Kimberleys, some of the groups, because they have a huge turnover of doctors and health professionals in that area, they were telling us that 25% of their time was spent going around and educating health professionals on what services they provide. Now, already, if we can free that up by acting as a platform as knowledge, so people can refer to it easily, we've freed up 25% of time that can be spent on core business. And that's not a difficult one to do. People not knowing the inclusion and exclusion criteria of available services. And in all honesty, some of our hospital services actually don't know their inclusion and exclusion criteria, which makes it very difficult for the rest of us to find it. So, what were our aims? To stimulate discussion between primary and tertiary care. And I have to admit, having sort of listened to Graham, we had expected a little bit of a bloodbath on some occasions with this, but it didn't happen. Once we got past people venting some of their grievances, there was developed an understanding of each other's points of view, and the realisation that some simple changes could actually make a big difference from how we communicate with each other and how we work together. To provide a platform for the retention of knowledge, there are huge amounts of wonderful knowledge. One of the first people we worked with was the eating disorder specialists, who had this amazing book that covered every service for eating disorders in WA. I'd never seen it before, and I'm sure I wasn't the only one. However, they gave it us in soft copy, and it now sits on our website. And I think most people have been very amenable to actually doing that. You know, we're not after taking any glory. It's after it being a group thing that covers the whole of WA, and we need to work together to make this work. So it's just, you know, we're not reinventing the wheel, as Graham said continually, and we have a whole community behind us that we can use their shared knowledge and their pathways to actually move this on quite quickly. Obviously, the provision of service information. It becomes so much easier. There was a lovely doctor in Bunbury who we have a section on exercise and exercise classes all around WA. And he said, so that's what they're doing Saturday mornings on the Esplanade. Yep, that's what they're doing. And to provide guidelines based on current WA practice. We try to make everything WA based first, and patient information and everything, and we will go to other areas if necessary. Though we are, as Graham said, working with some national ones that we've not quite got right yet, but we're a lot nearer, and that will hopefully make it easier. We're also working with some other jurisdictions, because there's no point all clinical editors across all these 35 areas working on independently on the pathways when we could work on them together and get a better result that can be used over bigger areas. Addressing service gaps. To begin with, we found this quite frustrating because there was all these service gaps we wanted to sort out and help, and it's hard to do. So you have to wait till you get to a certain critical mass, and then it starts happening. It starts happening without having to do as much. One of the slogans at WAFA is to translate complexity into simplicity, and this works well for this, so we've coined that and use it where available. So geographically, a bit like you, we face many challenges. We now cover the whole of WA, which is 7 country areas. So we need to collate information from WA, including these areas. Now, one thing that probably hasn't been highlighted quite as much as we should have done is the work of all the people collating this information. We have a whole team that sits behind us collating services over this area, and they need to start as soon as we start localising the pathway, because that job in a lot of instances is way bigger get the clinical editor's job in actually doing the pathway, and they don't get quite as much recognition as they probably should. One of the issues that we came across is in the Kimberleys, they actually have their own protocols. They have the Kimberley protocols, which they've put an enormous amount of work into over the past 10 years, and they are specific for managing certain conditions in the Kimberleys. Added to this, they also have a drug list, which is specific to the Kimberleys. So one of many issues that was being found was people were seen in Perth. They then went back to the Kimberleys on drugs that they couldn't get in the Kimberleys. So, and you know, why would you expect a doctor sitting in Royal Perth to actually know what was available in terms of services, medication and management in the Kimberleys? So it's taken a while. This one's been a long one. We've been 18 months negotiating with them. They were very nervous of us to start with. They felt we were going to come in and take credit for all the work they've done. It's taken us a long time to explain that we are a platform of knowledge. We are the holders of it. We are where we sit it, but we are not the owners of it. So now going forward, we link to the Kimberley protocols in all our pathways that they have a protocol on. So that's a big step forward. And recently we were discussing a pathway, and they said, well, we don't actually need to do this one now, because the one you have covers all the things we would like in it. So we saw that as a huge move in the right direction. And we go to them with pathways that are specific to their area and get their expertise, such as rheumatic fever. We're working with them on the pathway so that the pathway we produce is comprehensive enough to make sure we cover all of that. Yesterday we had 295 pathways localised. When we get to 300 pathways, we're having a big party. Purple balloons, streamers, everyone in Waffa will have it on their desktop. We will have cupcakes, and Magda's planned a few more things. Now you might, yes, this is because we're proud of it, but it's not just because we're proud of it. It's because to get Health Pathways out to the whole of WA, we need every single staff member at Waffa to think Health Pathways continuously. We need them when they go to GPs, when they go to meetings, when they go to talk to service providers. We need them to be mentioning Health Pathways. And this is another way of doing it. So, our priorities for initial development were from GPs. Since that time, as we've expanded and started working with the Department of Health, obviously some areas come in from hospitals, PHNs. We troll wide because it's important that we service as many of the priorities as possible. This is it's probably a bit small to see very well, I would think, but this is our plan, which shows that we now have a plan till 2019. Though I have to admit, Magda every so often sneaks in an extra pathway if someone gives us enough good reason. So when I commented that you are better off than us, you will see that after our launch we had a flat spell. And this flat spell was brought about by the fact that we spent a lot of time working out with the Department of Health how we were going to go forward as far as endorsing the pathways and ensuring that we were all happy with the sign-off and what that sign-off process would look like. So that meant over that period of time we were still writing pathways, but none of them went through the system because we didn't have a system. Since that, you can see that's gone up beautifully and it's continuing to rise. The other thing that we like is looking at the up graph below, which shows the returning users versus the new users. And we hit on average about 20% new users and 80% returning, which is where we think it should sit. So recently we were involved, we had significant problems in WA with our endoscopy service, which involved redesigning the referral and the criteria around the referral. So now GPs can only get referral to endoscopy if they fulfil these criteria. So as you can see, our top views on HealthPathways for 3 months was how to get your patient to an endoscopy. So things like this are actually great opportunities to get people to look at the HealthPathways site, and once they've got on the site, they will wander into other things. So we do tend to track where they look, because that's useful for us on knowing what's important and what people are looking at. Even if they're not localised yet, if we're getting a lot of hits on something, we will then say, well, maybe that's something that we need to move up in terms of localisation. So another thing we've been working on recently is reduction of the ENT waiting lists in WA. And it was delightful that they actually came to us. They realised they'd got to a position where the waiting list was growing faster than the number of people that they could service. So we obviously had a problem here. And although it was the first time we'd sort of worked together and there were some bumpy bits, I'm not sure hospitals are always that good at working with primary care, and probably in some ways we're better at informing primary care on what's changing than they are. But it was a good collaboration, and we are now at the stage that we have criteria for our ENT referrals. The criteria sit on HealthPathways, and the ENT departments triage against those criteria. So if those criteria aren't fulfilled, the GP will get a letter back explaining that it's been knocked back because of this, and if they look at HealthPathways, they can see what the criteria, and they can also see how to manage things if they want to remain in primary care. As I said before, we worked well with the eating disorders team. They were great to work with. We also found as part of that we linked them to a general practice who were really interested in actually working with eating disorders. They upskill them and they support them. So now we've already expanded the places young people with eating disorders can go. One of the things that we're working on this year and for next year with 3 other HealthPathways sites is early diagnosis with autism. Autism now can be quite reliably diagnosed around 12 to 18 months, and we've been working with the Telephone Institute who've enlisted the NDIS, who are prepared to take these children in early and give them support prior to a diagnosis being made, and they're going to roll this out through general practice, and some of the pilot areas will sit in these 3 HealthPathways locations. So again, it's making big change, and it means that primary care is actually part of making that change and moving forward. So we, for the last 6 to 12 months, we've invited ourselves everywhere. Whether they wanted us or not on some occasions. We've actually worked with the RACGP, which has been great, to actually do some webinars with our clinical editors, and we're looking at maybe setting up a 12-month programme where we bring some of our subject matter experts in to actually talk about the subjects that they worked with us on and the pathways that have just gone live. We do CPD events. Every time we launch a stream, we work on doing some CPD events with, again, the hospital specialists, the clinical editors and the SMEs. So we're giving a sort of rounded education. We are working hard at inclusion of country GP events. We've had some success in setting up country hubs in PHNs where the doctors come into, and then we link them with that, and and feed them as we would somewhere else. So those have worked well because country can often get neglected. We learnt a lot about country on our travels, and one of the first things that we did when we got back is put lists on our site of all visiting specialists to country, so the GP can easily go on site and find out who's visiting when. That was really simple, but it's been a good move to include the country. We also have a GP Connect magazine, which we make sure we get ourselves in as much as we can. And we try, when we see in conferences, if people are presenting on things that we've actually got pathways on, we actually contact them and ask them to use HealthPathways. So we get it wherever we can. So, lessons we've learned. Leadership. And leadership and support and enthusiasm needs to come from the executive level. But not just that, from everyone who works at Waffle. We need everyone when they're going out to see GPs, to see NGOs, to go to conferences, wherever, to be talking about health pathways. And did you know there's a new pathway? And we're working on that at the moment. And we work with different educators. Not perfect. I have to admit, I did go to a meeting with one of my SMEs the other day on drug and alcohol, who said to me, great that we're going to do some training funded by WAFA for you. Oh, that's good. So there are still hiccups, and the communication within the organisation needs to be continually worked on to make sure that we're all making the most of it. All feedback is good feedback. We've actually developed a policy where we see any negative feedback as a challenge. And I'm afraid to say that we actually actively go after that person, don't we? And look at converts. The picture of the donuts and the coffee has particular significance, because we have found that if we do get some particular negative feedback, we've got an amazing donut place in Perth. And if you arrive, having booked an appointment, clutching pistachio donuts and a few others and coffee, it's really hard to be mean to you. They look at you and go, well, maybe I was a bit harsh in those comments, and maybe we can work together. And that's actually been very successful. Flexibility. The PHNs are integral to Health Pathways, and as has been our Scope Health Agreement. It's been amazing, and it's allowed us, even though we were nervous, it's allowed us to move forward and get some really good runs on the board. I'm going to read this bit. So, it's always amazes me how something so fundamentally simple can have such wide-reaching effects. Simply by forming connections, one at a time, every working group, every meeting with a specialist, every education session, linking people in and breaking down silos. And we've been doing it for 4 years now, but it's probably only been in the last 12 months that we've started to reap the benefits of breaking down those silos. So yes, you will have a tough time for a while, but once you've got through that, it's amazing what can actually happen from that.